Welcome to today's eye review session. My name is Yejun, a second-year medical student at the University of Calgary. Our team here will present to you today the ophthalmic changes in schizophrenia as a link between ophthalmology and psychiatry. The two links between schizophrenia and the eyes that will be explored in this presentation is first the abnormal eye movements, and second the retinal abnormalities, or also known as retinopathies. In abnormal eye movements, there are different levels of eye movements that can go wrong, from reflexic eye movements to conscious control from the brain that moves the eye in an organized fashion to take in visual information. So more specifically, some of the examples we will explore is the impaired smooth eye pursuit movements and the limited exploratory eye movements. In terms of retinopathies, there are three solid findings in literature. First is the wider retinal venules for those with psychosis, and the thinning of a layer called retinal neural fiber layer, as well as reduction in the macular volume and area. And lastly, the increased perception of brightness and color intensity. This, in turn, also decreases contrast sensitivity. So before we delve further into making this connection between schizophrenia and the eyes, it's important, I think, to know what schizophrenia is. So schizophrenia is a psychiatric disease with psychosis that significantly impacts an individual's function. And while schizophrenia as a word means the splitting of the mind, schizophrenia does not mean a splitting of personality. Rather, schizophrenia describes an array of psychosis-related symptoms and behaviors. Schizophrenia is also a syndrome associated with many different symptoms associated with that, and it also has individual variations. And the symptoms are, as seen in these two pictures, classified into positive symptoms, negative symptoms, as well as cognitive ones, and we will explore this more in the next few slides. So there is a very important manual that psychiatrists often refer to, and this is called DSM-V, or the Diagnostic and Statistical Manual, the 5th edition. And this describes schizophrenia as a syndrome with two or more of the following 5 symptoms: delusion, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. And one important point is that at least one of the symptoms that the patient is experiencing has to be one of the 3 bolded bullet points: delusions, hallucinations, and disorganized speech. Delusion is a firm belief in a concept or an idea, despite any evidence that might be to the contrary. So for example, the FM radio is a message transmitted by aliens. That could be one example of a delusion. Hallucination is a sensory perception despite the source of the perception not being existent. So we have 5 senses, and the most common for schizophrenia is an auditory hallucination, where you hear noises or someone whispering or talking to you, despite there not being any sound in reality. There can also be visual hallucinations, where the patient see things. And there are also haptic or somatic hallucinations, where they might feel something on their skin or even inside. For example, they have a belief that someone implanted something in their brain, and they feel it. Last two, the gustatory or the taste sensation, and the olfactory hallucinations. These are rare. The catatonic and the negative symptoms are the last two. Catatonic behavior is divided into, there are 3 catatonic behaviors, including akinetic mutism, catatonic posturing, and wavy flexibility. In terms of negative symptoms, we have affective flattening, alogia, and avolition, and we will cover these in the next few. So the fourth symptom, the catatonic behavior, is a series of symptoms that involves lack of movement or communication overall. And we will describe three of these. The first is akinetic mutism, and this is exactly how it's described. Akinetic means no movement. Mutism means mute, lack of speech. And patient will experience both of these. Catatonic posturing refers to a very rigid and immobile postures, and we have this helpful GIF to illustrate that. See how the patient is very rigid, and he's also in a seemingly uncomfortable position as well. And the GIF also demonstrates waxy flexibility. So it seems like he's moving or encased in a liquid of wax. Right? The movement is slow, despite having initiated movement, albeit by the examiner. So the definition of this is the tendency to remain immobile in any posture, just like a wax has been encased over the joint and the muscles. So upon the stimulus, and there is significant resistance, and as the muscles slowly release and the limbs start moving very slowly. And finally, we have negative symptoms, which are deficit symptoms. And these involve minimal expression or interest in things around them. And these deficits can range from affective deficits, affective flattening that I've mentioned before. And this refers to patient having minimal facial expression, and anhedonia, which is a lack of interest in any activities, blunted affect, which is the diminished affect we talked about, and poverty of speech or allosia that was mentioned earlier. They are lacking in the amount of speech when communicating with someone else. And one more thing to add is avolition. This is when the patient has no motivation whatsoever to initiate something, to perhaps improve or enjoy an activity, even their hobbies. So that was criteria A for schizophrenia. There are many other criteria to determine if the patient has schizophrenia. Part B is whether a patient has one or more social or occupational functions that are significantly impaired. This includes the aspect of work, whether the patient is working as efficiently as before, hobbies, relaxation, if the patient is able to enjoy and relax as much as he or she would have liked, as well as maintaining relationships. This is referring to whether the patient can effectively maintain and nourish the interpersonal relationships. And C is duration. So at least 1 month of class A symptoms that we talked about earlier, but that's not enough. In total, 6 months of these symptoms needs to be continuously observed for the patient to be diagnosed with schizophrenia. And if you look at the picture here, 1 month in total would just be a brief psychotic disorder. Between 1 and 6 months is called schizophreniform disorder, and more than 6 is schizophrenia. And these are just how the diseases are classified. So the pharmacological treatment to schizophrenia is antipsychotics. There are 2 types of antipsychotics, typical and atypical. Atypical antipsychotics like olanzapine, risperidone, they block dopamine D2 receptors as well as 5-HT or serotonin receptors. The typical ones, like haloperidol, only block D2 dopamine receptors. Typical antipsychotic drugs are recognized as first-generation antipsychotic drugs, while atypical ones are second because they're newer. But they are also more expensive, although they have less severe side effect profiles. On the other hand, typical antipsychotic drugs are more affordable, but has more side effects, and are more likely to cause extrapyramidal motor control disabilities. Now, we will learn more about the link between schizophrenia and the eye in the next two videos.